All right, everybody, this is Section 3, Care of Postoperative Patients. We'll go over some of this in class, but this is just a quick review of what we will kind of cover in class, just to kind of make you aware of kind of what in this section to really pay more attention to and study. This just kind of defines when the postoperative period is. It begins when surgery is complete and when someone moves to either the PICU, like the care unit that they're going to be going to, or ICU. Sometimes they might go to like a day surgery or ambulatory care unit. Please familiarize yourself with all of the requirements and measures for the Surgical Care Improvement Project. Look that up and be real prepared to know what it is that is done preoperative related to that and what is reevaluated in the postoperative period for that. I know you will hear us talk about PICU. That is just considered the post-anesthesia care unit. It's a specific unit where people go to recover from anesthesia. So a lot of times you'll hear people call this the recovery room. Again, the main goal there is to anticipate, prevent, and manage complications after surgery. And as with any handoff communication, it is a huge safety goal that circulating nurses and anesthesia personnel have got to give a full verbal handoff report to a PICU nurse so that they can best really manage and prevent these complications. This is a little bit about the PICU nurse. They're really knowledgeable of anatomy and physiology. They have to have a broad base of knowledge. They have to know a lot about anesthetic agents and how they work on the body and know that pharmacology. They have to be able to manage pain. Sometimes they have to assist with extubation of endotracheal tubes. They have to be able to make very quick decisions and work real closely with anesthesiologists and surgeons in that area. They do body system assessments in an ongoing way. These are just a lot of the tenets of respiratory system assessment. They're looking for airway patency, whether gas exchange is good. They're looking at patterns of breathing. They're listening to breath sounds. They're looking to see if somebody uses their accessory muscles to breathe or have snoring or stridor, which mean that there's maybe some obstructive areas going on with their breathing. And then they watch for symptoms of respiratory depression or hypoxemia. In terms of cardiac assessment, they are doing very frequent vital signs, heart sounds. They're monitoring the cardiac monitor system continuously. And they're also doing like peripheral vascular assessment, looking for, perfusion into the extremities and making sure that those are all equal. In terms of neurological system, they're looking at cerebral functioning, the return of some of the consciousness. They're also looking at motor and sensory assessment after a patient has had an epidural or spinal anesthesia. Is that medication wearing off, and are they able to move their extremities in the same way they were before? They monitor fluid, electrolyte, and acid-base balance, which we will have an exercise later in a few weeks for you to work on with that. But overall, they're looking at all the volume of fluids going in and the volume of fluids going out, and trying to make sure that through that there's not a lot of loss of needed electrolytes, and that they are not having any severe alkalosis or acidosis issues developed. They're monitoring wound drainage, not just from an incision, to make sure that it's not draining a whole lot, but also through a variety of drainage type tubes that are used in surgery. They may be monitoring nasogastric tube drainage as well. For the renal and kidney system, of course, they're monitoring for urinary retention, where the kidneys, there's retention in the bladder and somebody's not voiding who doesn't have a catheter, or they're looking at the kidney function not producing enough urine in relationship to loss of output from other things like sweat, vomitus, and diarrhea. And of course, anytime that there is a urine output of less than 30 mLs an hour, that is reportable to the physician, and is not a good sign of kidney function. So often they may have to give fluid boluses or do potentially have to give some medications to try to see if they can get the kidneys functioning better again. They also assist the gastrointestinal system. About 30% of patients that have had general anesthesia will have nausea or vomiting symptoms. Anesthesia pretty much ensures that your peristalsis of your guts really slows down to a halt. And so that may be delayed for up to 24 hours. They're going to monitor patients for bowel sounds. And also, once you start to hear bowel sounds, are they then having flatulence and passing gas, because that's a sign of lower bowel function as well. They are going to administer different medications that help control nausea and vomiting. The NG tube drainage, these are some of the reasons that NG tubes can be utilized. Please make sure that you can recognize when some of those might be necessary. And it's important to really assess, and mark on the suction canister every 8 hours about how much is coming out, so that can be monitored adequately. Skin is going to be assessed, particularly related to the wound, but also areas in which they may have laid or been placed in positions in the OR area. Two key complications that can come from poor wound healing that are seen most often in 5 to 10 days after surgery is dehiscence, which is a partial opening of the upper layers of skin, and or evisceration, where the entire abdominal cavity may open. Patients need to be educated a lot about this, because this can happen after they're discharged because of the time frame it generally occurs. This is a picture of dehiscence and evisceration. You can kind of see with dehiscence, it's kind of the incisions open, but it's more the upper layers of the skin, and not all the way to where the bowel is exposed. Evisceration is when the bowel actually comes through the skin. You can see on the right there is a picture of a vac machine, and this is not used with evisceration, but if it is just dehiscence and there's no bowel protruding, a lot of times they will use this black sponge material and put down into the area of dehiscence and place the suction tubing apparatus to the vac machine, and it has a certain amount of pressure, and it will pull any fluid out of there or infectious material, and it helps kind of pull the edges back together and promote the growth of skin to kind of begin to heal together. So I wanted you to see that. These are just a couple of other types of dressings and drains you might see. The one on the top is one that has like a long piece of gauze in there, and you just gradually pull a little bit out each day and cut it off, and that kind of promotes the wound to kind of heal at the bottom, and kind of as you keep pulling begin to kind of like tunnel and close. The one on the bottom is a Jackson Pratt drain, which is kind of like a closed bulb suction type drain that you empty every 4 hours and measure the amounts that come out. And as that amount starts to get less and less, the doctor will a lot of times pull that drain out before discharge. There are a few surgeries where there's lots of drainage expected, where patients may go home with that, and then they have to be taught how to monitor and empty and measure that output every 4 hours at home. This is just another example of a type of dressing that can be applied, and it is pretty much like tape on each side with a opening that helps hold the dressing in place, but it's tied so that you don't have to take tape on and off all the time. Pain we've already talked about, but there are, according to National Patient Safety Goals, medication needs to be provided based on the extent of the surgery, the type of surgery, and really the length of the surgical procedure, meaning that we should be using that World Health Organization, grid in terms of severity of pain based on the surgical procedure. And again, we have to manage some of the emotional signs of pain as well. These are physical and emotional signs of acute pain that we talked about the other day. Of course, the increased pulse and blood pressure, increased respiratory rate. Sometimes patients will be having profuse sweating, restlessness. Older adults may get very confused. Nonverbal people may be wincing, moaning, and crying. These are some of the laboratory assessments that are typically done in the postoperative period. They want to look at electrolytes because of fluid loss during surgery. They also want to look at a complete blood count. And they're looking for white blood cell count to see if there's any elevations, but also a condition called bandemia, which is when neutrophil count is greater than 6%. And that means that you have a high level of neutrophils, which are immature cells. So they're being produced too rapidly to kind of fight off an infection. You may be obtaining specimens for culture and sensitivities. Arterial blood gases might be done to look at the acid-base balance in a patient. Urine and renal laboratory tests are done at times. And then for diabetics, glucose, of course, is monitored very closely because it ties in with a high infection rate. And serum amylase is often ordered for pancreatic surgery to be looking at that level. Potential for hypoxemia is there's highest incidence occurs on the second postoperative day. Main interventions that you want to be doing are airway maintenance, monitoring pulse oximetry, keeping your patient in a more semi-Fowler's position, managing oxygen therapy, doing breathing exercises, which includes incentive spirometry every hour, and mobilization as soon as possible. And sometimes that's hard to encourage patients to get to cooperate with. Of course, patients also have potential for wound healing and delayed healing. Your nursing assessment is to really look at the dressings. They are usually first change is usually done only by the surgeon, not by you. So you just have to wait till that's time, and then you'll start doing whatever dressings are ordered after that. Drains do provide a route for air, blood, bile. You want to keep clean handling of that as possible to prevent any kind of deep infections from occurring. A lot of hand washing there. Other interventions might include drug therapy. The patient might be on some type of antibiotic postoperative. They might need irrigation to treat a wound. They might need debridement to a wound. Or they might end up having to go back to surgery to help close a wound opening, like as we had with the wound vac. This is just an example of staples, which is a very common thing. Those usually come out about a week to 10 days after surgery, and a lot of times that's in the doctor's office, not in the hospital. These are some other pain interventions. Of course, drug therapy, and then other complementary and alternative therapies. Positioning and repositioning the patient. Some patients need massage, other relaxation and diversion techniques, and always, again, consider cultural influences regarding pain. Community-based care postoperative is very important to get set up and arranged. A lot of patients may need home care management, whether that be through a company or just with additional help from family members. They have to be taught how to self-manage themselves at home. Also, what healthcare resources are out there to them. Do they have the supplies to do their dressings at home? And we may sometimes have to, find ways to get that to them so they can consistently provide care. And make sure that they know that they have follow-up appointments and that they have to complete any antibiotic therapy, and how to manage their pain medications at home is a key thing as well.